our next speaker will be Dr. Berven, who will talk to us about the role of reduction in dysplastic spondylolisthesis.
Great. Well, thanks again to Kyle and Lee and Lionel. I think you really put together a terrific program. And again, I think the unique aspect of this program, we were talking about we do sort of 3 or 4 major spine programs. What's unique about this is bringing together the silos of sometimes the pediatric and adult population and learning from one another. And I think spondylolisthesis is a developmental condition that really spans the ages and obviously has an impact on the developing spine. And that impact can lead into adulthood. So understanding that spectrum over time, I think is terrifically valuable. So I had talked about other developmental conditions, Sherman's kyphosis, idiopathic scoliosis, and the impact over time in the case presentations. But I really want to hone in now on dysplastic spondylolisthesis, which I think is a distinct entity that we'll talk about. These are my disclosures, including research funding. I don't think anything is relevant to this talk. And what I'm going to talk about is, again, this conditions of the spine that transition from pediatric to adult, again, focusing on olithesis. And olithesis refers to a forward slippage of a superadjacent vertebra on a subjacent. I think so often, I'm looking to the fellows here, we talk about this so often, retrolithesis isn't a real word. That's sort of a paradox, right? You have a posterior subluxation. There's no such thing as a lateral olithesis. I don't know where these words come from, but you even see it in our literature, but that makes no sense, right? There's a lateral subluxation or a rotational subluxation, and olithesis is truly a forward slippage just in terms of etymology. And fundamentally, our goal is to try and restore lordosis at 5-1. And we've learned so much more now about our distribution of lordosis and understanding where that ought to be. And I think in circumstances where we inadequately restore that segmental lordosis from 4-1 or especially at 5-1, we really have a tremendous impact on global alignment adversely if we don't restore that. So we'll talk about some surgical techniques and I'll show you some case examples when in the adult, so in a pediatric case that was not well aligned, what happens into adulthood and why. So again, the concept here is the transition. It's when do we operate on the adolescent, understanding the natural history? When is it perhaps sensible to observe something into adulthood? And understanding the natural history of each of these things, or congenital conditions, neuromuscular, syndromic, and I went through the first 5 in our earlier cases, and spondylolisthesis is a really important example of when is it important to avoid the consequences of deformity progression, the consequences of increased kyphosis in the adolescent to avoid the adult consequences of that deformity. And again, I talked about this slide earlier. This is John Hall, who was one of my mentors during my residency, and I did my chief residency with him at the Boston Children's Hospital. And he used to say, thinking about when to operate is perhaps even more important than how to do the surgery. So understanding when, and again, we talked about the thoracic 1B or 1C scoliosis, so avoiding that progressing into a double major curve. And that's, I think, our major justification for operating on type 1 curves, is avoiding the progression of a structural curve below. And similarly with spondylolisthesis, avoiding a progression of deformity. It gives us the opportunity for when to operate early. The Wiltshire-McNabb classification of spondylolisthesis, I think most people are familiar with, and I left this in here for some of the trainees in the audience, but understanding the notion of dysplastic, isthmic, degenerative, traumatic, pathologic, I think this is a nice descriptive classification, but perhaps doesn't really capture some of the subtleties. And again, in this notion, here on the left side, a degenerative olithesis where the posterior ring is intact, as opposed to an isthmic olithesis on the right side. And in this case, I would consider this more of a dysplastic because of dysplastic features include the inadequate or the incomplete closure of the posterior ring, high pelvic incidence. These are things that biomechanically lead to the probability of a progressive slip, perhaps some facet joint dysplasia. All of these things are dysplastic characteristics. And this is where we see our larger degrees of deformity in dysplasia. So again, our patients with a high pelvic incidence, our patients with inadequate or incomplete closure of the posterior elements. These are the patients that develop the high-grade olithesis and with compensatory changes, including a high pelvic tilt, retroversion of the pelvis, and high kyphosis between L5, S1, and we'll describe that a bit more soon. So I think to some extent the Marchetti and Bartolozzi classification is what I emphasize now when teaching residents and fellows and trainees, and understanding that in broad categories we've got developmental, meaning conditions that occur with growth, and then more acquired. So acquired things are traumatic, post-surgical, degenerative, that happen with age. And to some extent in patients with a lower pelvic incidence, the nutcracker mechanism is more of an acquired type of mechanism, as opposed to developmental. These tend to be patients with a high pelvic incidence. So with or without lysis, these patients develop displacement, and these are the patients that are at risk for high-grade olithesis. The classification, I think, is worth understanding. This was developed by Hubert Lebel and Mac-Thiong and Tim Resco and others in the spinal deformity study group. And I think Vedat and I contributed to this as well. And looking at this, the main point I want to focus on is the notion of sacropelvic balance or alignment. So alignment in the lumbar pelvic area between L5 and S1, and then spinopelvic balance. And spinopelvic balance really refers to more the global alignment. And what I'm going to suggest here is, as we look at this discretely, it's really the patients who are type 5 and type 6. So the subset of patients who have a sacropelvic malalignment, meaning they've got a high pelvic tilt, they're compensating for their olithesis, and the patients who have global malalignment. These are the patients that are most important to get a reduction on. These are the patients in whom, when we don't reduce this, in whom when we fuse these in situ, these are the patients who end up with trouble. And I'll show you evidence for that. The subset of patients who are globally well aligned, and the subset of patients who don't have a sacropelvic malalignment, that subset is really a subset I think is more appropriate for in situ type of procedures without necessarily a reduction in deformity. So recognizing our patients with a high pelvic tilt, recognizing our patients with a global malalignment, that's when we want to do more. And I think most of us are aware of the controversy. And I think there's a big controversy if we were at a POSNA meeting versus if we were at a ISSG meeting or an adult deformity meeting. I would say SRS, but SRS is obviously mixed. But a lot of the POSNA people would really focus on, well, in situ is fine. I think people who see the adults would suggest it's not. And the analogy here, I'll just show you, obviously recognizing the importance of sagittal alignment is critical. And this goes back to the work of Mac-Thiong, looking at the correlation between C7 plumb line deviation and spinal tilt. Okay, so that correlation is something that he showed definitively. I think I've got it here. Really has a high correlation. So again, spinal tilt, C7 plumb line, these global metrics of alignment are highly correlated with worse health status. And this is actually in adolescence. I'll show you some work that we did in adults. But a high correlation suggesting a global alignment is associated with worse health status. And this goes back to, I think, David Bradford, who's mentor to many of us here, and Bob Winter when they were back in Minnesota, really looking at patients with severe spondylolisthesis, so patients with grade 3, 4, even grade 5 olithesis. And the fixation back at this time was mostly Harrington rods, distraction, and there was a high incidence of rod breakage and a high incidence of postoperative problems. And what they said, and I think this is still true, this is very insightful, is that really the slip angle, this is a parameter that's more important than the degree of olithesis. So correcting that slip angle between 5 and 1 has to be our goal. And this was recognized all the way back, in 1979. And what they said is in patients with a higher slip angle, these are the ones where the rods break, they have progression of deformity, they don't fuse. These are the ones we really need to pay attention to. So recognizing that slip angle, and in their situation, oftentimes that was actually associated with patients who had neural problems as well. So slip angle being the key thing to recognize. So here we may focus on the fact that yes, this is a grade 4 listhesis, right? It's slipped the full length. So if you look at Meyerding's classification, this is a high-grade listhesis. But more important than the amount of slip is actually the kyphosis between the L5 and the S1 here. So our surgical strategy, and I think I'm going to show you this case later, the outcome on this. I don't think I'm going to show it now, but I want to emphasize that the angle is more important than the amount of listhesis. And obviously, in this case, recognizing a high pelvic tilt, this is somebody who I would say globally is well aligned, but the sacropelvic balance is certainly off, or sacropelvic alignment. So this is a type 5, and this is one I would advocate reducing. And if we showed this in a case presentation, I think a lot of people would say, oh, just fuse that in situ. So again, our surgical strategies are characterized by a lot of variability. And this is where we really need an evidence-based approach. Oftentimes I say, anything that we do where there's a high degree of variation, be it, do we go front and back or do we go posterior only? What do we use for bone grafts as an example? What are our surgical strategies for dealing with 5-1? Anytime there's a high degree of variability, that variability is perpetuated by the fact that we don't necessarily have a great evidence-based approach. So our strategies could include decompression alone, and that's certainly something that historically has been used, and obviously a high degree of progressive deformity with that. Fusing in situ, a lot of present-day advocates of that, I'll show you. Fusing transosseous perhaps gives us better stability, but at the same time, maybe less opportunity for reduction. And then what are our opportunities to actually reduce the deformity? And these parameters I think we've gone through already, but the slip angle being the important parameter we want to reduce. So this becomes a challenge surgically of how do we create lordosis in the patient who's kyphotic? And where there's controversy is even in relatively recent literature, but the Finns who did a lot of long-term follow-ups, so Mika Pusa and Ilkka Helnius from Finland, they did a lot of long-term follow-up looking at patients with severe listhesis who were treated in situ versus reduced. And they actually showed that the subset of patients who were treated in situ did a bit better. When you look at overall satisfaction, that wasn't significant, but in terms of post-operative function, the patients actually did better and had less neural complications. Now, when you actually look at this in detail, so this is the argument that's classically used for we should just fuse kids in situ. The trouble with this is when you look at what their fixation was, this clearly is not, this was their fusion group, is, no pelvic fixation, and this is something that's bound to fail. So their technique of reducing this without adequate fixation is really, I would say, the reason why those people did so poorly. And so destabilizing this and then not fixing it adequately would lead to a worse result than just fusing somebody in situ. Yeah, I think that Jürgen Harms's work with the TLIF is really, I think, some of the best evidence we have for better results. And in his case, some high-grade cases for better results in terms of fusion rates, less implant failure, and less late complications. He improved slip angles by about 30 degrees and also improved sacral inclination somewhat, so reduced the pelvic tilt somewhat, increased pelvic tilt somewhat. But at the same time, out of 27 patients, 6 out of 27, so fully a quarter, had some L5 palsy. So the downside, the bit of paradox here, is putting the L5 nerve root at risk. So what's the real advantage to reducing a high-grade listhesis? I think improved biomechanics for arthrodesis, loading an anterior column, having better bone surface areas, being not expecting a fusion in tension, better segmental and global alignment. But the disadvantages clearly are possible compromise to neural elements, again, higher rates of neural trouble, and the possibility of a loss of fixation. And a loss of fixation meaning we're putting our screws under a lot of strain. And that's where a pelvic fixation becomes part of it. So just show a couple of examples. This is a case I showed earlier. This is, and what I ended up doing in this case, let's see if I can show you pre-op to post-op. So again, a high slip angle. And this is a case I did a while ago, but what actually happened here is I was working the L5-S1 interspace, and as I was reducing it beyond a grade 2, meaning as I was reducing it to less than 50%, the L5 signals dropped out. And I'll show you the technique in a minute, but essentially sacral dome osteotomy, kind of shortening that 5-1 segment. And as I continued to pull L5 back, that L5 root, despite my best efforts to mobilize it, was really under a lot of tension. I could actually feel the root. So what I chose to do here is leave this as a grade 2. So you see there's still 50% anterior displacement. But you see, and I went transosseous with the fixation. So if I'm going to leave it with less than 50% reduction, then I think a T-lift cage doesn't really fit in there very well. So I use the T-lift cage if it's more than 50%, if it's reduced to less than a grade 2. But otherwise, this is where I think the Bolman technique works out well, which is transosseous from S1 into L5. I also followed that with a fibula from S1 into L5. And the pelvic fixation being such an important part of this, without the pelvic fixation, this is bound to loosen. But the point I want to make with this case is that we reduce the slip angle, not necessarily the actual degree of slip. There wasn't a complete reduction of the degree of slip. And you see the pelvic tilt also improving. So going from 45 degrees change of lumbar kyphosis, so going from 30 degrees kyphotic to 15 degrees lordotic, and that increased the pelvic tilt quite dramatically. And those are the parameters that really are associated with health status. Here's some work we did in adults, actually, looking at the correlation, 37 adults with this higher grade spondylolisthesis. And essentially what we showed here was fixing slip angle was most improvement in parameters of pain, functional limitations, and overall, and mental health, actually. So fixing the kyphotic, making patients from kyphotic to lordotic, improve that. And then also looking at pelvic tilt. So there's a subset of patients in whom their pelvic retroversion, so their pelvic tilt actually reduced. That was also highly correlated with improvement of appearance, pain, and function, and a physical composite score. So again, even in adults, this was somewhat important. Those parameters made sense. Here's a 17-year-old boy. He's from up in Nevada. At the end of high school, he was actually a cross-country runner and rower. If I recall, he was actually more of a canoe player, but he was unable to play sports after his sophomore year in high school. Developed some L5 numbness and weakness. It was progressive by the time he was 17. And here's his dysplastic spondylolisthesis here. You see L5 on S1, incomplete formation of the posterior elements. And on a MRI scan here, you can see the dramatic foraminal narrowing here on L5 bilaterally. So the combination of foraminal narrowing as well as, in his case, a type 5 deformity, so high pelvic tilt with global alignment. This is one where the technique that I like to use here, especially for a young boy, is to take my osteotome, do an osteotomy across the sacral dome, and actually shorten between L5 and S1. And then, so here's my osteotome working in the L5-S1 interspace, really developing that L5-S1 interspace, mobilizing L5 on S1. And this is where I could get it less than a grade 1, or certainly less than a grade 2. I think a T-lift is a very nice way to get a circumferential fusion there. And again, you notice the presence of robust pelvic fixation here. So when I get this well reduced, I think that's a nice opportunity to put in an interbody from the back. Here's a video. Let me see if I can, would you help me to play that? And you can just see some of the technique. This is a different case here. But what I do is get in between L5 and S1, and this is actually using a paddle. And the combination of a paddle and reduction screws kind of mobilizing between L5 and S1 and then pulling that back. And you can move on from there. But the point being that really spending time to take the osteotome across the top of L5 and then using a combination of paddles with your reduction tools to try and, once you get L5 really well mobilized, and that requires taking down the iliopelvic ligaments, sort of ligaments between L5 and the pelvis, the iliolumbar ligaments. That requires really seeing the L5 nerve root as it goes out over the front of the sacroiliac. Really trying to get all the way around the outside of the disc is really valuable here. And once you get to the point where your paddle can really make L5 almost wobbly, because remember, there's no longer any connection with the pars, right? So you've essentially got the pedicle of L5 and nothing else posteriorly. You've taken off even the very top of the pars next to the pedicles. So getting that wobbly allows you to pull it back pretty easily. And generally, as you saw there, I pulled it back and then put it in the interbody. I'll wrap up here with to some extent, I think anterior surgery is something we're all familiar with, And in my lower grade cases and in my patients with perhaps not such a high sacral slope, I really like the ALIF. I think the ALIF is a terrific technique for, and this is again a lower grade case, but the ALIF is a terrific technique for mobilizing the L5, getting this well lined up and getting really rigid fixation. I always back this up posteriorly after an ALIF because I think that in the absence, so doing a standalone ALIF here, Alex Vaccaro showed a high rate of failure of those. So I'll always back these up with screws. But to me, this is a technique that really gives the most robust and reliable fusion rates. And quite honestly, as much of a fan as I am of the TLIF, I think a circumferential fusion with an ALIF is stronger. And in my low-grade cases, I think most of us in low-grade cases are doing this. But what about doing this in a high-grade case? And here's an older woman. She's 59 now, L5 radicular pain, had a lot of facet injections, decreased ability to stand and walk. And here's how she presents. Again, your very typical high-grade olithesis, significant slip angle here, high pelvic tilt, foraminal narrowing between L5 and S1. And in this case, quite honestly, I think my typical historical approach would be with a TLIF here. But in this instance, I chose to go anteriorly because I thought I had a reasonable pathway. Here's her CT scan. Again, you can see the severe foraminal narrowing, and I felt that I could probably get a better restoration of her alignment with an ALIF. So here's a shot you see again the foraminal narrowing on the MRI scan. So here's a shot intraoperatively is I've got my malleable here in front of S1. And what I've done here is essentially done a discectomy at L5-S1, and I put 2 screws into L5, and I've still got my inserter onto my inner body implant. So you see here, there's still significant displacement between L5 and S1, but if I've really done a good discectomy and mobilized this significantly, just with a gentle push, I can get that really nicely reduced between L5 and S1, get some good posterior disc height, and then lock that in place. So reducing it from the front, lock it into place. Again, there's a lot of strain on this construct, so I'm always going to fix that in the back as well. So actually, I chose to put a plate on it and then fix it in the back. But you can see the dramatic improvement. Let's see here, from pre-op to post-op. I guess I don't have pre-op next to it. But the dramatic improvement both of her pelvic tilt and her kyphosis. And again, the kyphotic correction. So in terms of, when will I go anteriorly? I'll take a close look at the vascular anatomy. I'll take a really close look at the sacral slope. And oftentimes I feel that if I can get in there well, an ALIF can be a nicer way than a TLIF to get that reduced from the front and a more stable construct. Very quickly, I've got to wrap up because we've just got 1 minute left here. What happens when we don't reduce? Well, here's a couple examples. A patient who was fused down in Los Angeles, L4 to S1, and rods breaking at a young age. So this is somebody who was actually, I think, 21 when she came to see me. She had her fixation done when she was 16 years old, but no inner body, high strain on this, really probably inadequate pelvic fixation. Her rods broke, so I revised this with a front and back construct and actually improved her lumbar sacral alignment quite a bit with the front and back construct. Here's another example. Just, you really can't expect this inadequate fixation to hold. L4 to S1, nothing in inner body, nothing transosseous. So these S1 screws predictably broke. And again, I ended up reducing this actually from the back, and I used a more of a partial reduction Bowman technique to get fixation from L5 to S1 and then sacral screws. And then this final example of somebody who was fused in situ as a child. I think you see it better on a CT scan. L5 spondylolisthesis, sort of a grade 5 spondyloptosis, fused from 4 to 1 as a child, and then developed progressive degeneration above, which is pretty predictable. So it was fused with interspinous devices up to L1. So now they've got a really rigid, long construct, and this I ended up treating with an L5 PSO, L4 PSO, and then that's him postoperatively. But I would argue that had he had a reduction, or had he had some improvement to that lumbar sacral kyphosis as a child, he could have avoided this as an adult. So overall, I think what I want to point out here is that in dysplastic olithesis, the lumbar pelvic parameters have an important impact on health status. And the role for reduction, I think, is especially true for a grade 5 or grade 6, a grade 5 and grade 6 in the McThiel and Lavelle classification. And again, I would make the argument that recognizing the long-term sequelae of in situ fusion makes the argument for us that reduction is important in those patients with lumbar pelvic or global malalignment. So thanks for the opportunity again to share that to this audience.
Thanks very much, Sig. The classification that you discussed, I think there's the Bell classification, kind of hinges on whether the patient is overall balanced or not balanced. The question I have is, because there's some effort dependence in that static X-ray, someone might be given their best effort in appearing to be balanced, but when they walk around and are fatigable, they may not be balanced. So what's your take on, whether someone who's balanced stays balanced over time as they get older and they're less fit, or is there another way we should be thinking about kind of overall balance?
Yeah, really important question. I think when we look at global alignment or balanced global alignment, when we look at that, there is a component to that probably is effort dependent. And that, in fact, I know Chris and Vedette had done some work with actually asking patients to walk before their X-ray, kind of getting them fatigued, and then really not having our X-ray technologists say, hey, stand up as straight as you can, but say, stand in a natural posture after being fatigued. And they showed that actually patients did stand with more malalignment. I think the subtlety of the classification that captures that is the notion of it's not just global alignment. So yes, somebody may get their global alignment compensated for by reducing their thoracic kyphosis, bending their knees, extending their hips. But the fact that the classification also has the sacropelvic part of it. So one of the compensations is gonna be the sacropelvic part. So somebody, for example, might be a grade 5 because they're compensating, right? Their global alignment is compensated, but they're gonna compensate by increasing their sacropelvic tilt. And that, I think, gets captured in the component. So it's got sacropelvic alignment and global alignment. So they'd still be a grade 5. So I'd still argue that they should be reduced because the sacropelvic malalignment is just as important. So the 5s and 6s, and I agree with you that sometimes somebody might be a 6 after being fatigued. They may compensate to a 5, but I don't think that compensation will come from the sacropelvic. And that's why I think that's an important part of the classification.
Yeah, I agree. And I think, you mentioned the lower extremity compensatory mechanisms that go kind of unmeasured unless you're getting an EOS film. So hopefully the next, classification that comes out takes into account those as well.
Yeah, it's an interesting paradox because, should we make these classifications more complex, or should we require a long film that includes the knees in the classification, because then it becomes less generalizable, right? And Chris and I were talking about this yesterday about, well, if we classify a risk of complications of adult deformity surgery that has to include telomeres and methylation and aging markers and hydration of muscle or water content of muscle. So if we make this too complex, then to some extent, it's not going to be applicable to the vast majority of people, right? So some of our predictor variables have to remain generalizable. So I agree with you. Being more sensitive to compensatory mechanisms could be useful. So recognize when patients are extending their thoracic spine or bending their knees. At the same time, as we make it more complex, it's harder to use. So, yeah.
Sig, one more question for you. Great cases. In several of those cases, really required sacral dome osteotomy. Can you give the audience a little bit tips and tricks on how to safely perform it and minimize L5 nerve root complications, given that a lot of times compressed and stretched already?
Yeah, great question there. And I think the fundamental technique for posterior correction is going to be mobilizing that L5 body. And again, really the only thing that's holding that L5 body in place is our 4-5 facet joint. but there's no connection to posterior elements, especially once we take down our interspinous ligament between 5-1. There's no meaningful connection to the 5-1 facet joint. So then the disc becomes what holds us. So often, the mobility between a standing film and a supine film tells us something about how much we can easily get. But when somebody's still got a lot of displacement, even in supine, we know we're going to have to do some work at 5-1. I think that the critical part of that work is going to be to not put too much strain on the 5 roots. So we know by work that was done by Bridwell and others, looking at when we reduce somebody from a grade 3 or 4 to less than a grade 3, or to less than grade 2, that's when that L5 nerve root has a lot of strain on it. So how do we minimize strain? I think number one, visualizing the nerve root, right? So taking off the top of the pars above the fracture, so right below the pedicle, really expose that. Looking directly at the nerve root, making sure we kind of take any soft tissue attachments, so our lumbar-pelvic ligaments, the transverse process of L5 onto the Sequelae, taking that down, and feeling strain on the nerve root. Nerve monitoring can be important here, but fundamentally actually shortening the sacrum. That's what allows the mobility without putting too much strain, without putting too much vertical displacement on the L5 nerve root. So shortening the sacrum. And then in terms of technique, what I'll do literally is take my osteotome right at the, well, first I'll do a discectomy, but oftentimes, even at the start of my discectomy, I'll put my osteotome right at the top of the L5 pedicle, sometimes even taking some of the top of the L5 pedicle and shave that right down posteriorly. Shave that down. Then I'm trying to get anterior height without posterior displacement, right? So getting lordosis without necessarily getting posterior displacement. And shortening, shortening the back of S1. If you look at that, some of those myelograms, you see how the back of S1 really tents the thecal sac. So I'll take that whole posterior part of S1 off, because my interbody implants isn't sitting on that anyway. So I'll take that off, and that helps allow me to get lordosis anteriorly without posterior height increase. Yeah. Thanks again for the opportunity to contribute.